Hello everyone, my name is Jaime Renfro. I am a DNP candidate at Maryville University, and I am going to present my DNP project of development of clinical guidelines for the post-bone marrow transplant and cellular therapy adult patient. I am currently a practicing nurse practitioner in an oncology setting, specializing in malignant hematology and bone marrow transplant and cellular therapy. So thank you. I would like to take the time to thank my DNP chair, Dr. Petrov, and my additional reader, Dr. Brunworth, and my community member, Dr. Kelly Atkinson. So thank you very much. A little bit about the background of my scholarly project site. It is in mid-Missouri. It is Community Oncology Center, planning to offer a new service line of bone marrow transplant and cellular therapy. In an effort to meet the needs of our community and the patients that are receiving oncology care, even in our referral locations and then coming back into the community, it was noted that there was a lack of clinical guidelines at the project site that were specific to any element of the bone marrow transplant, but specifically the post care of bone marrow transplant and cellular therapy patients. And so the project site began this endeavor, and so as part of accreditation and standards of care practice, it was important to develop a clinical guideline to help navigate clinical decision making for our institution and those that provide care here. So early on, it was identified that the Iowa model of evidence-based practice would best support this project as I identified specific triggers that needed to be addressed. So problem and knowledge focused triggers were identified early on in the project site, and the need for clinical guideline development. And so here is modification of the Iowa model specific to this project. So as you can see, there was a clinical and a patient need identified, that there were issues that needed to be addressed, and for accreditation requirement specifics, that was also there and identified. And so developing a new service line comes with many things that need to be addressed. And specifically, even without the implementation of a new service line, bone marrow transplant and cellular therapy is not a new service to offer to patients. So patients would before be referred out and then come back into our service area, and they were still not getting their needs fully met. So regardless of the implementation of a new service line, there needed to be clinical guidelines for these patients. And so was it a priority to the institution? Absolutely. And then I assembled the research, the literature review, developed the guidelines, and then from there the guidelines were evaluated for quality. The element that is not yet completed to complete the actual framework would be the actual institution implementation and compliance monitoring, and then the annual evaluation to ensure that the guidelines still continue to meet the evidence-based practice that is out there. So during the literature review, there was multiple things that needed to be gone through, both from an accreditation standpoint and standards of care, but also as a theme to understand what it is that is being missed whenever you're developing post-transplant guidelines. And so here are some of the governing organizations when it comes to specifically this service line. So Centers for International Bone Marrow and Transplant Research, ASTCT, CIBMTR, these are all acronyms for organizations that provide oversight for such service, with Foundation for the Accreditation of Cellular Therapy, or referred to as FACT accreditation, being the accrediting body, similar to that of like Joint Commission for the institution. This is specific to transplant and cellular therapy. So themes that came out through the literature review were that evidence-based clinical guidelines is obviously best practice. Follow-up care coordination was found to be lacking in community settings for patients who have received this line of service. Specific to allogenic transplant, graft versus host disease monitoring and management is something many providers and clinicians are uncomfortable with or unfamiliar with because they lack the knowledge base or the resources that they need to assist with taking care of these patients. And then once the guidelines are developed, it is important that guidelines are actually evaluated for quality themselves. And sometimes that does not occur, and it was found that the agree-to tool is an evidence-based tool that would further support the recommendation and quality evaluation of the guidelines that were developed during this project. So let's talk about the guidelines a little bit. Several elements had to be met in order to have a complete guideline available. And guideline being, used in conjunction with clinical assessment and decision making. So for the evaluation of the post-transplant or cellular therapy patient, these are actually done in time intervals at 30 days and 60 days and 100 days. And so it was broken out to give specific timelines of when patients needed to be seen, not just only for our clinical setting, but for their community provider who's also going to see them in long term. And so during those visits, what is expected? What labs are we monitoring? What diseases or infections could we be monitoring for? And if imaging would be due at any point in time. And some of these treatments and even the pre-treatments in order to get a patient to this level comes along with a lot of risk and a lot of monitoring that needs to be done. So this guideline actually specifies some of those intervals, so then that way the clinicians have a little better understanding, can gauge how frequently they need to be looking for stuff and what they need to be looking for. Most people are not specifically thinking, I need to be looking for CMV or EBV in my patient, but it is different in this patient population. We talked about performance scoring. It is important to monitor that because if a patient is failing or getting worse, it is important that they get back to our institution and we can kind of monitor. Sometimes we have to fine-tune and figure out why a patient is starting to fail. And then we provided, here's an example of our Konofsky's performance score, and we give the range that we want our patients to be in. Transplant toxicity assessment. There is a tool that different things that need to be monitored for. People don't think about revaccination, and that is one of our biggest missed opportunity for our patients. Our patients receive very myeloablative, lymph node depleting regimens prior to receiving their cellular therapy or transplant, and these patients require revaccination. So revaccination schedule itself is not a common practice for the adult population, so it is important that we provide that guidance to their community provider because these schedules start at 6 months to a year, and these patients have long since moved back into their community. And then graft versus host disease assessment and monitoring. A lot of this is going to come with a lot of communication and direct conversations between our transplant providers and their community oncologist or their community provider. However, we needed to provide the actual assessment tool that is available to them and then give them the resources and how to get back to us. So the guideline itself is very comprehensive, a lot of information, but it was written by one person, being myself, and so it is important that the guideline is also evaluated for quality. And so that's what occurred after this. Identified an evaluation tool using the appraisal of guidelines for research and evaluation instrument, and it it is utilized to evaluate the quality of clinical guidelines. So taking it a step further than just developing the guidelines, but now we have to assess that they are of quality, and that is the bulk of the actual project itself, is that evaluation. So it is broken down into 6 domains, as you can see here, and so this tool provides the instrument, it provides the instructions on how to use it. It is very clear and easy to use for the reviewer that is given to them, and so the Agree To tool was chosen for this DNP project for that specific reason. So early on, I was able to identify 5 reviewers, very specific, because the content itself is very heavy in evidence-based care, and so you want to use people who have a good foundation of knowledge, and at least in the content, but also the actual understanding of what is expected of quality for this project using the tool. So I identified 2 physicians, both of them being bone marrow transplant, cellular therapy trained and specific in the program. I chose 2 nurse practitioners, one being DNP, one being FNP, both in oncology. However, neither one of them are specific into malignant heme or BMT CAR T. And then one being a pharmacist, especially with the different vaccinations and medications, who also has an administrative role within the program. And so felt that this was a good mix of reviewers. So each of the stakeholders was provided the Agree To instrument. They followed the instructions, and they were able to evaluate the clinical guideline using, in the 6 domains, there were 23 items, and it was on a 1 to 7 scale. 7 being the maximum points possible, meaning that they strongly agree, and then 1 being minimum, and the threshold goal for each domain and overall was equal to or greater than 85%. And so the following slides will go over this scoring. So here is the total points calculated to the total points possible per domain. And again, you could see how this equals out. Blue being the points received for that specific domain across all 5 reviewers. And then here is how those points, how the score was scaled here. Domain 1 reaching 100%, domain 2 94, domain 3 was 88, 99, 97%, 90, and then overall the total was 93%. Thus it was well above the threshold of equal to or greater than 85%. Additionally, the overall recommendation by each reviewer was that they agreed that it was recommended for use in its current state without any modifications. You could see the overall guideline quality scoring here by each of the reviewers as well. And so the data analysis was performed utilizing the Agree To tool instrument instructions, and that is how this information came out. Some of the limitations of the actual project and the guidelines was the inexperience of the program itself. Only one of the reviewers and one person on site actually has developed and performed these procedures and any quality or quantity to where they could provide sufficient expertise. And so that is one of the limitations. We found that there was a huge gap in knowledge base, as even in oncology, bone marrow transplant and cellular therapy is not part of the general education that is provided especially to the nursing staff or even to the nurse practitioners. It is done in addition to, however, it was not part of the core knowledge here. Another limitation is once the guidelines are approved, they do get assigned to the assigned user, the people that's been identified that should be reading the policies, such as the bedside nursing staff or maybe the clinic staff or the APRNs that are part of the oncology program. However, once it is read and acknowledged in your email, it then is housed in a data repository called NavX, which is owned by Policy Tech, and then they have to go in, find it. It's not actually under BMT, it sits under oncology, so that in itself makes it a little bit difficult to have access to the guidelines after they have acknowledged them. One of the things that they have worked to try to help with the limitation of this guideline is if there is something that is being occurred or being done, the institution is trying to link the guideline into maybe an order set, such as, clinic return visit. The order itself would have a direct link into the clinical guidelines. So there are some things that are trying to be done on the back end if possible. Another limitations when it comes to something of this magnitude is the burden of resources. These patients are being seen often, sometimes daily. They're getting more frequent labs. They're needing to be assessed more. They get sick more often, and so the burden of resources is evident as we have to increase our patient volume. We are increasing the amount of visits, and when you already have a strained resources, bedside nurses, bed crunch, even medications, the resources of getting the chemotherapy and different things can be burdensome. So when you add on something like this, it can be hard on your resources. And then another limitation of this actual project itself is the implementation analysis is not available because the guidelines had not been implemented, even though they have actually been accepted by the institution and are being moved forward through the approval process to be implemented. That information is not available at this time. So overall, as far as the guidelines were recommended for overall use, the two BMT providers that have experience, one of them being the program administrator and medical administrator, did recommend the use of the guidelines. So the likelihood that this guideline will move forward in its current state and be approved by the institution and implemented is very high. The long-term patient outcomes, regardless if the institution moves forward with having a bone marrow transplant program here, should improve. There has not been any type of post-transplant clinical guidelines provided. So now when these patients do return into our community, or if they receive services here and have long-term needs, we now have a clinical guideline to help with those decisions. And then the potential for this guideline to be available and a part of the overall institution's accreditation process is pretty promising. One of the things that also came about during the project was the gap in the nursing knowledge. So thinking about the implications for practice, really thought about how we needed to give the staff a solid knowledge base, and so we did provide a 2-day nursing education course for the bedside nursing staff, the clinical staff, and the infusion nursing. And so that really was just based on pathophysiology of oncology, the different diseases that we'll be treating with this resources, and the preparatory things that happen in post-transplant. And then we also provided a half-day APP course. Even if they are not the primary providers for these patients, we do have something called a symptom evaluation clinic that is a shared responsibility, and so we rotate through that. And so it was felt that the APPs should all have at least a foundational knowledge of what to do in emergencies such as neurotoxicities or different things, plus the expected outpatient care management or the long-term patient care follow-up, because, you know, I can't be there every day, somebody else may not be available, but if we can tell them how to take care of these patients in the long term or what to look for, then they won't be as nervous to take care of them, and then was able to show them where the clinical guidelines are as well. And so the overall goal of program accreditation, improve patient outcomes, and just increase resources is very important to the implications of the practice for this institution and this patient population. So we developed an awareness that clinical guidelines need to be evaluated using a validation tool, a validated tool, and to make sure that it is meeting the expectations of quality. It is important to evaluate outcomes in the future, specifically how the patients are doing, the compliance of, the expectations of the guideline. And then the guideline itself moving forward through the institution has been delineated to be evaluated annually, as would be expected for both accreditation, and as a new program you certainly want to make sure that you are making sure everything is up to date and meeting the current standards of practice. And it is exciting to see that this project itself could be sustainable in helping achieve accreditation for the institution, and that it helped create a theoretical framework for future projects here, and that evidence-based care is the best care that we can provide for our patients. Again, thank you so much for listening, and I would be open to any questions that you have. I know that is a lot of information, so thank you for taking your time, and I do have my references. Again, thank you so much. Have a great day.